Now, what is a pleural effusion? A significant pleural effusion is large enough to produce a pleural fluid strip of more than 10 mm wide on the lateral decubitus radiographic view or by ultrasound. So, more than 1 centimeter of pleural effusion is a significant pleural effusion that needs to be drained. What is the Light's criteria for pleural effusion? The pleural fluid protein by serum protein is less than 0.5, pleural fluid LDH or serum LDH is less than 0.6, or pleural fluid HGS is less than 2/3 of the upper limit of normal serum LDH. What is the causes of transudative? They are cirrhosis, heart failure, nephrotic. And what is exudative? Inflammation and malignancy, and infection like tuberculosis. Low glucose pleural fluid you will remember by REM, rheumatoid arthritis, empyema and malignancy. High amylase pleural fluid is seen in pancreatitis and esophageal rupture and malignancy. Chylothorax, there is increased triglycerides more than 110 mg per dl in the pleural fluid. Most common it is post-op or post-trauma. Pseudochylothorax is seen in rheumatoid arthritis due to cholesterol crystals. So triglyceride more than 110 mg per dl is chylothorax. What are the indications of drainage of effusion? If there is a split pleura sign, if the pH is less than 7.2, if there is low glucose, gram stain or culture is positive, and loculations or adhesions are present. What is split pleura sign? It is seen in empyema because of the inflammation of the pleura. The empyema which has been infected secondarily, you will insert a drain. How do you know empyema versus parapneumonic effusion? Parapneumonic effusion is localized around the pneumonia and it resolves with antibiotics, while empyema is in pleural cavity and it needs the pigtail drainage. It is a secondary infection. In neutrophilic predominance yani polymorph predominance, you will find in P3 parapneumonic effusion, pulmonary embolism and pancreatitis. So PMNs in PPP, parapneumonic, pulmonary embolism, pancreatitis. Lymphocytic predominance in cancer, TB and post-cardiac surgeries. Pleural fluid pH less than 7.1 predicts development of empyema, and normal pH is around 7.64. For tuberculosis, you can do a Siminat, but its yield is very poor. You can do pleural fluid ADA. ADA more than 40 is diagnostic of TB, and you can do interferon gamma or mycobacterial PCR in pleural fluid. So ADA, interferon gamma and PCR. Next chapter is hemoptysis. So assessing the amount of expectorated blood is difficult. Patients are mostly not able to tell. What is massive hemoptysis? It is 100 ml in 24 hours to more than 1000 ml, and a value of 600 ml in 24 hours is expected by many. What is massive hemoptysis? More than 600 ml per day or 150 ml per bout. Okay, you need to keep the bleeding lung down and provide oxygen. We keep the bleeding lung down so that the blood coming does not obstruct the airway. If the patient is unstable, we need to do a rigid bronchoscopy and coagulate the bleeder. If this patient is stable, we can do a CT bronchial angiography. And Rasmussen's aneurysm is when pulmonary artery can be a source of bleed too. So normally in 80% of the cases, the source of bleeding is a bronchial artery, but in Rasmussen aneurysm, pulmonary artery can be a source of bleeding as well. What are the sources of hemoptysis, causes of hemoptysis? So it can be infection, structural, vasculitis, cardiopulmonary, neoplastic, iatrogenic, traumatic and miscellaneous. Rasmussen's aneurysm is a false aneurysm of a dilated blood vessel crossing the wall of a tubercular cavity. So there is a dilated pulmonary artery crossing the wall, going into the wall of a tubercular cavity, then it ruptures and it bleeds. So causes are infection, structural vasculitis, cardiopulmonary, neoplastic, iatrogenic, traumatic, and miscellaneous. How do you diagnose and treat a minor hemoptysis? You do history and examination, and if it is minor, you do a chest x-ray. If it is negative, suspect acute bronchitis and do a follow-up primary care physician. But if it is positive, the chest x-ray is positive, do not suspect acute bronchitis. Send CBC, KFT, urine analysis, coagulation profile, and follow up with pulmonology. Next is algorithm for massive hemoptysis. So what is massive hemoptysis? More than 600 ml or 400 ml of blood in 24 hours or more than 150 ml in one bout. If the patient is stable or not. If the patient is stable, you do a chest x-ray and send the functions, the blood parameters. Then based upon the renal function, if they are normal, you do a multi-detector CT, and if they are abnormal, you do a CT without contrast and consult cardiothoracic surgeon. If the multi-detector CT is negative, you admit to ICU in a stable patient, mind it. And if the multi-detector CT is positive, means there is a bleeder identified, you call IR and CTVS to collab and stop the bleeder. If the patient is unstable, emergent IR and CTVS consult is done immediately without any X-ray labs or anything, and you do a bronchoscopy, a rigid bronchoscopy. If the patient is stable after rigid bronchoscopy, the bleeding has subsided, you do a multi-detector CT. If it comes positive, call IR for bronchial artery embolization. If the CT is negative, admit to ICU. If the patient after rigid bronchoscopy and coagulation of the bleeder is patient still unstable, call surgery for thoracotomy and stopping the bleed. So if you summarize, if a patient is stable, you have time to do a chest x-ray, KFT, do a CT without contrast or with contrast based upon the KFT, and decide accordingly. If the CT is negative, admit to ICU. If CT is positive, send for bronchial artery embolization. But if the patient is unstable, you do not have time to do all this. You need to page them immediately, do a rigid bronchoscopy, coagulate any visible bleeder. If the patient becomes stable, then follow the stable guideline, do an MDCT based upon the renal profile. But if the patient is still unstable after bronchoscopy, immediately take for surgery. What is bleeding control? Defining bleeding control. So historically, surgery was the treatment of choice if bronchoscopic interventions, which is your rigid bronchoscopy, failed. But now surgery is reserved for massive hemoptysis from specific condition like iatrogenic pulmonary artery injury, thoracic trauma, or bleeding for a tracheoinnominate artery fistula or a tracheostomy site.